Alterations in reproduction, disorders of the male reproductive system. Now, this is not included in your core curriculum, but it does happen very commonly in young men, so I wanted to make sure I brought this to your attention. We're talking about torsion of the spermatic cord. We have a twisting of that spermatic cord that involves rotation of the testicle, and it twists the cord around the artery, kinking it and compromising blood flow to the testicle. It will occur in adolescent boys and those whose spermatic cords are congenitally unsupported. These young men will have sudden, sharp testicular pain, local swelling, nausea, vomiting, chills, and fever. We diagnose it by physical examination and getting a history. Treatment requires immediate surgery. We have to relieve that constriction of the blood flow, and it does require surgery to do that. Nurses need to make sure they're providing appropriate analgesia. Scrotal support may be necessary. Monitoring for drainage postoperatively is also very important. These are highly vascular areas, and we need to make sure that we're not having bleeding. Erectile dysfunction is also known as impotence. It is an inability to achieve an erection sufficient for or long enough for intercourse. It may be related to inefficient neurological stimulation, inefficient arterial blood flow, trapping of venous blood. It may have physical and psychological origins, such as some medications like antihistamines or antihypertensives. And a decreased libido may be due to medications, disease processes, a decrease in hormones, etc. Even though men will retain the ability to achieve an erection throughout their lifetime, sometimes the decreased amount of testosterone will affect their libido or their desire for sexual intercourse. It may also be due to disease processes such as diabetes or cancers, etc. If they have a lot of pain, this is not necessarily a priority. And again, some medications can also affect their libido. We diagnose erectile dysfunction through nocturnal penile tumescence and rigidity test, and we can also do vascular ultrasound studies. So medical and surgical treatment. There are some drugs that can cause impotence once again, so maybe we need to change those drugs to something else. Some drug therapies are available to facilitate penile engorgement, such as your PDE5 inhibitors, which can be used for erectile dysfunction, for BPH, and pulmonary hypertension. Contraindications are major cardiovascular disorders or a concurrent use of nitrates. In other words, if a client is taking nitroglycerin or they're on a nitroglycerin patch, they should never use this type of medication. It does create hypotension because it's causing vasodilation. It can also cause a headache, flushing, dyspepsia, priapism, which we'll discuss here in just a little bit, and visual loss. This is going to be like your sildenafil and all of those drugs, your Cialis, your Viagra, etc. And testosterone is another medication. It is actually a hormone and is used for hormone replacement. It is contraindicated if there is an androgen responsive tumor. Adverse effects is it can cause pileosis of the liver. In other words, it can cause significant liver damage. It can also cause hepatic or liver neoplasms, cholestatic hepatitis, jaundice, abnormal liver functions, fluid retention, weight gain, and clot formation. Any hormone replacement is going to have the potential of causing clot formation. This medication can be administered in a variety of ways, and one way is a patch. And if you remember back with pharmacology, when we administer a patch, this needs to go in an area where there is not a high vascularity, so we would never put it like on the scrotum. It needs to go on like the shoulder, the upper arm, the upper back, again, places where there's not a lot of high vascularity, because that increases the medication absorption. We also want to make sure that we're not putting it in an area where there is a lot of hair. If there is no place without a lot of hair, we may have to clip the hair, but we would never shave it, because we can create those micro abrasions that once again would increase the absorption of the medication. So for erectile dysfunction, in addition to medications, we can also do vascular surgery and penile implants. Nurses need to make sure that we're educating on medications, along with the potential complications and prevention following penile implants. Priapism, I'm sorry, I skipped right through that slide, is a persistent erection without sexual stimulation. It can be caused from a vascular problem, a medical condition, and can be a side effect of medication. These gentlemen have discomfort. It does interfere with arterial blood flow and urinary elimination. Tissue damage can occur if that erection lasts longer than 6 hours, and that can result in permanent damage. So very important that this is not ignored. It does need to be addressed. And often treatment will include vasoconstrictive medications. We can insert a needle into the pockets of blood and actually drain that trapped blood, or emergency surgery. And these gentlemen definitely require a lot of emotional support. So talking about BPH, benign prostatic hyperplasia. This is an increased number of cells in the prostate, and the prostate is a gland that actually surrounds the urethra in men, and it results in a decreased diameter of the prostatic section of the urethra. There's usually a gradual onset, and this is normal to have enlargement with aging. These gentlemen have difficulty urinating and emptying their bladder. They may have difficulty even getting their stream started. They may have a weak urine stream. They may have urgency when they need to urinate and nocturia. We diagnose with a digital rectal exam, or DRE, a cystoscopy, an IVP, and blood chemistry tests. With gentlemen with BPH, their PSA might be slightly elevated. We can also do a transrectal ultrasound. So to manage this, we need to monitor the size of that prostate with DREs. We can do drug therapy. There are alternative therapies, and we can also do surgical procedures. The one that I am most familiar with is going to be the TURP, or TURP. It's the transurethral resection of the prostate. In other words, they go through the urethra to get to the prostate and then decrease the size or remove the prostate that way. We can also do a prostatectomy which is complete removal of the prostate, and that is often done through the perineal area. Very important for nurses to educate on how to empty the bladder. These clients need to void often. They need to lean forward, bear down. They may need to sit to empty the bladder. Drink small and frequent amounts of fluids and limit alcohol and caffeine. We also would recommend limiting decongestants, because decongestants can cause urinary retention anyway. Postoperatively, these clients may require bladder irrigation to remove debris or clots. And we also need to monitor these clients for output and blockage postoperatively. So basically what's going to happen is we're going to have a urinary catheter inserted into the bladder to provide irrigation, and this irrigation is going to continually flush out the bladder, because a lot of debris and blood clots can actually be can accumulate within the bladder following a TURP or prostatectomy. And this is going to continually flush it out. So we put like a 3,000, or not a liter, but 3-liter bag of fluid hanging that is going to drain into the bladder. Then we have the actual catheter that drains the fluid out of the bladder. Then we have a third pigtail that we can connect a syringe to, that we can actually flush or manipulate potential blockages. Now, there are some medications that can be given for BPH. One of those is going to be finasteride. Some herbals that may be given may include like your saw palmetto. There are a variety of things out there, but basically it's just to help facilitate urination in these gentlemen. Again, because of the issue with urinary retention, these gentlemen are going to be at an increased risk for infection. Remember, anytime we manipulate the urinary tract system, we are going to have some bleeding. So they are going to have some blood, bloody urine initially. Prostate cancer is a common male cancer and is the second in cause of cancer deaths following lung cancer in men. These gentlemen have increased testosterone. They may have a high-fat diet or a family history. All of these have been linked to the diagnosis of prostate cancer. It does occur in the periphery of the prostate gland. We do see the genitourinary symptoms, and untreated cells can be spread by the bloodstream and lymphatic system. These gentlemen also have frequent urination, nocturia, dysuria, hematuria, hemospermia. In other words, they also have blood in their ejaculate, the sperm. They have erectile dysfunction, back pain. They may also have pain down the leg with metastasis. We diagnose through rectal examination. The PSA is a test that is pretty specific to gentlemen that do have prostate cancer. It will be elevated. We can do a transrectal ultrasound, X-rays, MRI, CT scan, the IVP, and we also see an elevated serum acid phosphatase. We treat it by doing annual screenings beginning at 50 years of age and at age 45 for African Americans or clients that are first-degree family history with prostate cancer in less than 65 years of age. Depending on the size of the cancer, we may just observe it. We can also do surgery, radiation, hormone therapy, or a combination of any of those. Surgery would include that suprapubic prostatectomy. We can do a radical prostatectomy, a bilateral orchidectomy, which is removal of the testicles, and we also need to be aware that there's potential complications. Removal of that prostate may potentially affect their ability to achieve and hold an erection. Cryotherapy can also be done. Radiation therapy is used alone or with other therapies. And hormone therapy. Men that have stage 3 or stage 4 carcinoma, we see the anti-androgenic or estrogenic drugs. Unfortunately, these do have feminizing side effects. And we can also do immunotherapy. So question, true or false? Prostatic screening should begin for all men at age 60 years. This is false. That is age 50 for most men, but high risk, including African Americans, are going to be age 45. Testicular cancer is the most common cancer in males that are 15 to 35 years of age. In other words, the younger men. It does have a higher occurrence in white males. We may also see a higher occurrence in men that have had cryptorchidism. In other words, they've had that spermatic torsion, or excuse me, the men that have had a failure of the testes to descend into the scrotum. Early degeneration of cells and undescended testes or abnormal cellular changes, and it usually will involve a seminoma or non-seminomas. These gentlemen will palpate scrotal swelling or a hard non-tender nodule in the testes. They may have abdominal pain, general weakness, or aching in the testes. And we do teach young men how to do the self-examination. This should be done usually after a warm shower or a warm bath because it just allows for easier palpation. Diagnoses, we may see some tumor markers. We can do an IVP. We can also do a lymphangiography, a CT scan, or an MRI. Treatment will depend on the stage of the disease. We can do an autologous bone marrow transplant. We can do surgery, a radical inguinal orchiectomy, which is the removal of the testes. We can do spermatic cord ligation, which is basically cutting that cord. We can do a radical retroperitoneal lymph node dissection, also chemotherapy and radiation. It is important to address the topic of sperm banking prior to surgery. If these men, and they are younger men, want the option of fathering a child later on in life, then they may need to bank some sperm. Scrotal support postoperatively is very important. We also need to manage their pain and provide postoperative teaching.